Il me fait plaisir de vous présenter notre premier panel. Depuis plusieurs années au Canada, comme ailleurs dans le monde, les partenaires de la santé ont dû innover afin de lever les barrières à l'accès aux services de qualité et sécuritaires dans la langue de choix du patient ou du client. Parmi ces innovations, la mise en place de normes d'accessibilité linguistique apparaît comme une solution prometteuse. Une entente a été conclue entre la Société Santé en français et l'Organisation des normes de santé, Health Standard Organization, HSO, la filiale de développement des normes d'agrément Canada, afin de développer une norme d'accessibilité linguistique. Grâce à cette entente, une norme sera développée et rendue disponible pour les établissements de santé en 2018-2019, et cette norme agira comme un important levier afin d'emmener les établissements à intégrer des pratiques d'accessibilité linguistique comme gage de qualité et de sécurité pour la population de langue officielle vivant en contexte minoritaire au Canada. C'est le fruit d'un travail de plusieurs années du côté de la Société Santé en français, appuyé de la Société Santé et mieux-être en français du Nouveau-Brunswick, d'un comité de pilotage formé de direction générale de nos réseaux et de plusieurs experts des plus engagés. Les panélistes font partie de ces experts et nous vous partageons leur vision et leur expertise au regard de la transformation des systèmes de santé pour offrir des services dans un contexte linguistique minoritaire. Je vais maintenant vous présenter nos trois panélistes. Donc, la première personne, c'est Mrs. Guerful Roberts. Donc, Mme Roberts comes from Wales, and elle a une maîtrise. Elle est maître de conférences à l'École des sciences de la santé de l'Université de Bangor, au pays de Galles. Elle est à la pointe des efforts visant à promouvoir l'usage du gallois dans la recherche et l'éducation en santé et à appuyer la transformation des organisations sur le plan de la sensibilisation linguistique. Ses travaux de recherche s'intéressent aux moyens de faciliter l'accès à des services en langue galloise et de soutenir la planification et le perfectionnement de la main-d'œuvre dans un contexte de soins de santé bilingue. Guerful a beaucoup publié dans le domaine et elle collabore à la question du bilinguisme dans le secteur de la santé avec ses collègues du Canada, du Pays basque, où elle donne des conférences devant des publics internationaux. C'est une amie aussi de la santé en français au Canada. Donc, j'inviterai Mme Roberts à venir s'asseoir ici. Ouais. Dr. Aitor Montes, du Pays basque d'Euskadi. Dr. Montes est originaire de Bassori, au Pays basque espagnol. Dr. Montes est bilingue et a pour langue maternelle le basque et l'espagnol. Après des études de médecine à l'Université du Pays basque, il s'est spécialisé en médecine familiale et communautaire à l'hôpital Galdacao. Il travaille comme généraliste à l'unité des soins intégrés de l'Osakidetza, qui est l'organisme sanitaire basque dans le comté de Debagoyena. On ne m'a pas donné la tâche facile. I hope I say it well. Il est promoteur de l'usage du basque dans la prestation des soins primaires aussi bien qu'hospitaliers, conformément au principe d'une prestation centrée sur le patient, sachant que l'usage du basque constitue un enjeu sur le plan de la sécurité et de la qualité des soins. On a appris ce midi en parlant que Dr. Montes est l'un des rares médecins qui rédige toujours ses notes cliniques, ses dossiers cliniques pour ceux de ses patients dans la langue de leur choix. Donc, dans la langue, soit le basque, soit l'espagnol. Et il signe aussi des articles d'opinion dans divers quotidiens en basque et en espagnol. Donc, Dr. Aitor Montes. Okay. Madame Leslie Thompson, du Canada. Donc, Madame Thompson est la force motrice derrière le mouvement People Powered Health, déclenché par Agrément Canada et toute la nouvelle organisation des normes de santé. Après avoir été nommée PDG en 2016, elle a dirigé une consultation mondiale de 12 mois et un processus de conception opérationnelle. Avec son équipe, elle travaille maintenant à mobiliser la puissance et le potentiel des gens partout dans le monde qui partagent leur passion pour l'atteinte de soins de santé de qualité pour tous. Ses racines cliniques en tant qu'infirmière autorisée, continue à exercer une influence sur son incessante poursuite de la qualité et de la sécurité dans les soins de santé. Elle est aujourd'hui reconnue à l'échelle internationale pour son travail au chapitre du partenariat avec les usagers pour améliorer les résultats. Grâce à tout ce bagage, Mme Thompson est la bonne leader au bon moment pour HSO et Agrément Canada, deux organismes en mouvement qui mettent au point des normes mondiales en matière de soins de santé et des programmes d'évaluation novateurs qui permettent aux gens de sauver et d'améliorer des vies dans leur milieu de travail. Madame Thompson. Good afternoon and welcome to the rendezvous. We would like now to each of you to explain to us the context of and strategies of your respective countries or perspective of Accreditation Canada regarding the linguistic issues. And we're going to start with Mrs. Roberts.
Merci beaucoup. Madame et Messieurs, merci mille fois de votre accueil chaleureux. C'est un tel honneur d'être ici avec vous aujourd'hui. Diolch yn fawr iawn I chi am eich croeso cynnes, fel un sydd wedi bod digon ffodus I fod yma hefo chi yn Ottawa, yn y gorffennol. Mae'n hyfryd bod nôl yn eich cwmni. There's a little bit of a flavour of Welsh for you. And now I must apologise. Merci. But I must apologise now in turning to English because my French is not good enough. I didn't study hard enough at school, so I do apologise for that. So I thank you very much for your warm welcome. It's such an honour, it really is an honour to be here with you today. When Caroline Vezina kindly invited me to this conference, she explained to me that it was an opportunity to bring together a range of key stakeholders who are committed to enhancing linguistic access to health services for Francophone and Acadian minority communities, whilst hosting what she described as a family reunion. Now, in the short time that I've been here, I strongly sense that feeling of being amongst family and friends, a collective spirit and a passion that suggests to me that there's important work to be done, policy and practice improvements to be established, and inequalities to overcome. Now, thousands of miles away, in a country about 400 times smaller than Canada, in Wales, isn't it amazing that we share such similar experiences and commonalities? And these also fuel our passion in Wales to enable linguistic access to speakers of Welsh, the indigenous Celtic language of Wales, to enhance the quality of our healthcare services whilst protecting our safety, our dignity, and our integrity as minority language speakers. Now, in the bilingual context of Wales, where over 500,000 people, or 19% of the population, are Welsh-speaking, the Welsh language now has equal and official status with English. And the Welsh Government acknowledges that, and I quote here, strengthening Welsh language services in healthcare is now regarded as a priority, since for many people, language in this context is more than just a matter of choice, it is a matter of need. They proceed to explain that it's essential that there are no barriers to receiving services in Welsh, and that Welsh language services are offered proactively, widespread, and of an equivalent quality to those offered in English. Now, by But establishing the official status of the Welsh language has been a long and an arduous journey. Back in time, the exclusion of the Welsh language from public administration for over 400 years meant that the Welsh language became marginalised and the status of the language was eroded. And this situation, it had a detrimental impact on our attitudes as Welsh speakers and our confidence. And that in turn meant that we inherited a legacy of feeling inferior about our language. And that still contributed towards its rapid decline. Whilst over the years the changing political landscape of Wales has played a significant part in the revival of the language, as Welsh speakers we still experience discriminatory attitudes and language oppression, all of which have a detrimental impact on our readiness and our opportunities to engage effectively with healthcare services. Now, in spite of its troubled history, the devolution of Wales in 1999 has proved a significant turning point for the Welsh language, which is now at the core of our national identity, our legislative frameworks, and indeed our health and social care strategic policies. And the equality principle that's embedded in our Welsh Language Act of 1993 has been strengthened now in the Welsh Language Measure of 2011. And it was this that gave the Welsh language official status in Welsh alongside English and established the role of the Welsh Language Commissioner. It made provision for promoting and facilitating the use of the language, and it created a procedure for introducing duties on some organisations, including healthcare providers, in the form of language standards. Meanwhile, amidst growing concerns regarding the impact of failures to deliver Welsh language services in the health sector, particularly to vulnerable groups, the Welsh Government in 2012 published its strategic framework for Welsh language services in health and social care, and a follow-on framework then in 26, and it's aptly called More Than Just Words. This confirmed the way in which meeting the linguistic needs of service users is inextricably linked to providing good quality, safe and compassionate care. And the strategy itself, it's based on two very important principles. The first is the concept of language choice being replaced by a new emphasis on acknowledging the language needs of Welsh speakers who use our services. And secondly, adopting the principle of the active offer from your language legislation here in Canada, it introduces a new framework for identifying language need and then planning Welsh language services without someone having to ask for them, which means creating a change of culture that takes the responsibility away from the patient or the client or the service user and places that responsibility firmly on the shoulders of the service provider. Now, this calls for a responsive, whole system approach with an emphasis on mapping, planning, and developing the workforce, embedding strong leadership that steps up to the responsibility for meeting users' language needs. Now, we acknowledge in Wales that establishing such a significant cultural change is going to take time, and we recognise a host of ongoing challenges. But there are strong indications that we are making progress in the right direction. And this was particularly evident in our annual conference last month, an event similar to this, where health and social care stakeholders from across Wales came to celebrate successful initiatives and share best practice. And only a few weeks ago, a report published by the Welsh Language Commissioner suggests that Welsh services are improving and people are confident that their rights to use the Welsh language are starting to take root. Now, just to close, given the close parity of our linguistic experiences and their significance in providing safe, good quality care, I look forward very much to the presentations and discussions here over the next few days, which will no doubt fuel our determination and our resolve to take action. Diolch yn fawr iawn i chi. Merci beaucoup.
Thank you, Mrs. Roberts. Now, Dr. Montes.
Hello, bonjour. Je suis un médecin de famille dans les Pays Basques. Je ne sais pas français. Mon langue maternelle sont l'espagnol et le basque. Mais je ne parlais pas français, mais je parlais en anglais de souris aussi. So I have these papers to help myself if I have some doubts in English, okay? So, as she has pointed out, we have to take into account the context because there is not a standardized methodology to achieve language appropriate and patient-centered healthcare. So it's very important to take into account our context. I live in the Basque Country, and for most of you, the Basque Country is completely unknown. It is a stateless small nation located in Western Europe between France and Spain, straddling the boundary. So there is a northern France or French Basque Country, les Pays Basques, Saint-Jean-de-Luz, Saint-Jean-de-Puy-de-Port, Vaillon, and the southern Basque Country, the Spanish Basque Country, where I live. So we live under different administrations, like maybe the Kurds, for example, different states, and even within the state, different administrations. So we have le département de Pyrénées-Atlantiques, à la France. Le français, c'est la langue de la République, the only official language, so the Basque is not an official language, and it is out of courts, out of education, out of healthcare. And in the South Basque Country, we have two regions, or autonomous communities. Euskadi, the Basque Autonomous Region, where the Basque language is official, and in the east, Navarre, en français Navarre, la région de Navarre. Northern Navarre, southern Navarre, and it is only official in the northern part of Navarre, and not in the southern part. So we have a debated nation, a broken nation. I work in the Basque Autonomous Region, and that we have our own National Health Service. I mean, the regulation, the administration, the planning, the managing, the funding of health and social care is under the responsibility of the Basque Ministry of Healthcare, because we have our own autonomous or self-government. And we have an NHS system which offers public and free and universal access to every citizen. It's free. And in the last years, we work following the integrated care model through clinical pathways and through creating new organizations, healthcare organizations, merging hospitals and primary care units in single structure, single organization. So I work in an integrated care unit, or OSI in Spanish, ESI in Basque. I work in the Bagoiena Integrated Care Unit, which offers healthcare to a population of 67,000 people in a catchment area where 66% are fluent Basque speakers. And I work as a general practitioner in a very little town of 1,500 people in a circle of mountains, a lovely place, where 80-90% are fluent Basque speakers, and 70-75% use Basque on a daily basis. And every children, 100% of our children, attend primary school exclusively in Basque, and all of them are Basque speakers. Very important because they are our future. And I deal with my patients in two languages every day, in Spanish and in Basque. And I write the medical records in the patient's language of choice. It's very important. And so take into account that we are a divided nation, but it is not an official language everywhere. And to offer healthcare in patients' language, we have developed our Basque language schemes. Our NHS was created in 1983. Well, we achieved our autonomy or self-governance, I think it was in 1980. In 1983 was created our own NHS that considered that the first Basque languages scheme was launched in 2005 or 25, I don't know in English, 2005. So we have been 22 years late. And now it's working the second Basque language scheme since 2013. And well, just to remark that, well, we are promoting the language of choice of our patients, the preferred language. And now, since 2015, our patients can choose the language. And we work with electronic clinical records. We do not work with handwritten records. So when I deal with a patient, in the main screen of our PC, of our computer, of our application, I can see the E logo. That means that this patient wants to be attended in Basque. So it's very easy to identify our patient's preferred language. And I think it's very important to, first of all, to know our patient's needs or what they want. Just this. At this moment, it started 2 years ago, and at this moment, about 100,000 and 170,000 people have chosen the Basque as the language of use. Taking into account that is a very small country with 2 million people only. So in 2 years, 100,000 and 70,000 people have chosen Basque. But unfortunately, we have not grasped the concept of active offer. We have launched campaigns to encourage our patients to choose the language. But anyway, I think that it is not their responsibility. It is our task. So I think that an honest active offer will be that we should offer to our patients and the admission points or in our surgeries and our office to offer them the language of choice. Okay, maybe a question that is quite different is the language profiles. What is language competence? Language proficiency. So we have established 4 levels of language proficiency. First, second, third, fourth, of course. And it changes. We have our own assessments and our own requirements, and taking or considering the social-linguistical environment, how many people, how percentage of people speaks the minority language and where. And secondly, the health organization itself. I mean, it is not the same primary care, specialized care, or general services. So the first priority level is primary care, of course, nurses, general practitioners, and admission points. In admission points, the 100% of our staff must be bilingual. For example, the admission point of an emergency room. I work in a bilingual setting, so in the bilingual settings, we, the doctors, must achieve or fulfill the second level of language proficiency. That's very easy, anyway. And in primary care units, in bilingual settings, the 80% of the staff must be bilingual. Primary care, for example, dental services are quite different. They are not our priority, so only 40% of the staff in dental services or dental care must be bilingual in a bilingual setting, so it changes. We have to take into account the organization, primary care, specialist care, and the sociolinguistical feature. Okay, so these are maybe our differences. We are trying to establish bilingual pathways, full clinical pathways in the language of our patients from primary care to specialized. How? Well, just identifying patients' needs, of course, and then identifying and recruiting bilingual professionals. But it is only a proposal. We have established only one in my unit. This is my contribution, the urology service in Basque. So I even make the referrals, I write in Basque, and the urologists answer me in Basque, in patient's language, I mean. And well, our aim, our goal would be to establish in a second stage in the future the bilingual medical records. 2 years ago, or 3 years ago, we established a work group called the Bilingual Clinical Records Work Group to face this challenge. And our aim, our goal, will be to establish with the patient's preferred language registration and with the bilingual clinical pathways, and at the same time developing informatical or computer bilingual applications which enable the professional to use his or her language as a language of work, to transfer the language barriers issue from professional and or healthcare giver and user relationship to language barriers among or between professionals, because it is a responsibility and not patients. So it is our aim, our goal, but this is not, we are working on it and take into account that we face the same problems, because for most of our colleagues, this is not a priority subject. For my monolingual, I mean English speaker or monolingual speakers, professionals here in Canada or in Wales, or Spanish monolinguals, there are not language barriers. So well, more or less this is what we are doing in the Basque Country.
Thank you very much. Now we're going to go to Mrs. Thompson, who is the CEO of Accreditation Canada.
Good day. Thank you. Bonjour, everyone. And it is just a real pleasure to be here. And on the panel, I enjoyed your comments very, very much. And I have the privilege of, I want to give you a little bit of an overview about Health Standards Organization and Accreditation Canada and some of the work we are doing together with SSF to really make some very concrete and practical inroads into addressing the challenges that you are all speaking about today. At first, with the introduction, some of you may know well Accreditation Canada. Accreditation Canada has been around for 60 years, and now we have been involved in the accreditation of healthcare facilities in every part of the healthcare ecosystem, from hospitals, remote rural nursing stations, Aboriginal communities, health systems, primary care, long-term care communities, small diagnostic centers, everywhere where service is delivered, we are. And those assessments are based on a variety of standards. And when we went through our strategic planning just over a year ago, we came up with the realization that we needed to make the standards under which assessment programs were built much more rigorous and to raise the bar. Sometimes when you have the assessment body and the survey and the standards development in the same organization, you end up lowering the standards. And what we were finding is that people, when standards were getting too hard, they were saying, well, we don't need to do that, or let's lower the standard, or let's not put the stake in the ground of what the right thing should be. So what we've done is we've taken out of the national accreditation program, taken out the standards development role, and that is now in what is called Health Standards Organization, HSO. And HSO, why is this so important in Canada and beyond? HSO is now an organization by virtue of the way in which we will be developing standards. We have just been recognized by the Government of Canada as what's called a Standards Development Organization, an SDO. What does that mean? It means that the way we develop standards can then be designated as national standards of Canada. So why is this important? It's very important in the context of today, because as we, in our work toward helping to improve quality and safety, we understand completely and deeply the challenges that linguistic barriers can provide. In fact, we provide services in over 32 countries, and our standards are in 7 languages. But even though the standards are in 7 languages, we know the very real problem about access to services for linguistic minorities and getting access to service in language of choice is a very real barrier in Canada and beyond. So I am just so pleased to be talking about the partnership with SSF that actually started way before I arrived in 2014. And what we've done now is move toward the very exciting moment where we are officially now, as part of this new process of developing what will become a national standard of Canada, a very specific standard for that will be called Communication in Minority Language Situations in Canada. So and right now I'm very pleased that our distinguished panelists are participating in the technical committee that is meeting tomorrow, that is advancing this development of the standard. And this is a very important announcement I wanted to share with you, because this is now putting the thinking and the talking into action. And I'm very excited. Thank you. And with that standard, then if you imagine what that standard then, as it goes, what is in the standard? So it's, and we can talk a little bit about this throughout the panel, but there are some very specific things. So it's being co-designed with and sponsored by SSF, and what it's going to address specifically are what are those organizational structures and processes that are required at governance and leadership levels that support and ensure effective communication. So the organizations that would be assessed, and there will be self-assessment tools and assessment programs developed against this standard, they will need to demonstrate that they have the governance and leadership levels that support the effective communication and service planning in their data collection, development of policies and procedures. They must have adequate resources, staff education, and training. So you can imagine what our real goal is ensuring that this standard, when it's developed, is adopted and upheld in every single publicly funded healthcare service in Canada. That's where we're going to need, yes. We're going to need your help on that, because the ideal would be that this gets embedded in a legislative framework in every province where there is no opting out. That needs to be the real goal. But these also, and we will work toward and with our partners to move in this direction. And this will also, the standard is structured to influence right at that point of care, what is required, what conversations need to take place, how people assess the adequacy on the appropriateness of those services and at the admission, assessment, treatment, end of life, discharge planning, and transfer of care. So throughout the care continuum. So with this, there will be the standard, then there will be and that will take time. They're not going to finish all the work in a day. You are actually part of a technical committee that has 25% patients and users, providers, academics, international faculty. This is very much part of the robustness of the process. There will be public consultation on the standard, and that will be something that we will work together to ensure with SSF and others that there's great awareness of everyone about the standard so that they can comment on it and get the best of all of your input as well as it develops. And then once that happens, it's about an 18-month process. And then we as HSO will be able to designate that, if it, as the standard fulfills all its requirements, as a national standard of Canada, as an official SDO. And then we start on the journey of actually supporting the adoption and the effective implementation. But not to wait for that, we are working again in partnership with co-designing those self-assessment tools, co-designing the assessment methodologies so that by the time that the standard arrives, that we are ready to go and gets that all embedded in the system. There are many other things I can perhaps come back to as we talk because this standard is one of a number of standards that not only we want it standing on its own, to make sure it has an appropriate spotlight, but we want that embedded into the core programs and standard assessment programs that accreditation runs in Canada and around the world. As an example, our HSO standards have been adopted by the Netherlands, and they're provided in Dutch and French. For essentially the same assessment Cumentum program that is used in Canada is used there and in Brazil and in Kuwait. And what we want is now to make sure that all of those, as this standard gets developed, that it also will penetrate all those other countries as well, and we will work together to make sure that this standard that Canada is taking the lead on is adopted by not only every community in Canada, but around the world. Thank you.
Thank you very much. Isn't it music to our ears to hear that? I have a couple of questions, and we're going to ask if people have questions as well. My first question is, language barrier can be a real, even dangerous roadblock to integrate care with patients and families as full partners. How can we break down those barriers? Someone wants to start?
I was very encouraged to hear about Health Canada's investment today, to Louise Bouchard and the team, because I really feel that data is so vitally important here. Without data, we can't plan. We need that data in terms of the language profiles of our communities, but we also need data in terms of our healthcare professionals. So certainly in Wales, there's work to be done to map our regional language profiles.
I agree entirely with her. I think that, well, first of all, to identify our patients' needs or our patients' choice, what they prefer. This is, from the VASC perspective, the most important thing, to establish a registration of how many people want to be attended in Basque. The path was with the other one, but I think that maybe it's important to remark that, okay, to offer healthcare in patients' language is our responsibility as health professionals and organizations, but we need, or probably it is beyond our capacities and abilities. For one reason, we need to establish partnerships with communities the local communities or regional communities at all levels, but as well with institutions or administrations, especially with the education system. This is what we are doing, or what has been done in the Basque Country, because the greatest stumbling block to achieve healthcare in patients' language is the lack of bilingual professionals. How to recruit bilingual professionals if there is not a bilingual education system? So in the Basque Country, we have promoted, we are trying to develop a bilingual education system promoting the minority language. So I think it will be very important to offer bilingual education to every children and every young people in Canada. I mean education in English, of course, but as well in French at all levels. I think it will be very important to offer higher education, university, in two language as we have. At this moment you can study medicine, for example, only the first 3 years entirely in Basque, but you can study medicine in Basque and Spanish in the Basque Country. I think it will be very important to achieve exactly the same thing, nursery and medical schools in Welsh and English, and furthermore to embed the subject, the issue of language in education, in higher education, because the other stumbling block is the lack of language awareness. So we need, of course, to study medicine and nursery in French and English here in Canada, but to study as well as a compulsory subject how important the language is and what is a patient-centered care. So I think these are two good things. I mean, to identify your patient needs, to try to organize and recruit bilingual professionals to establish full clinical pathways in patients' language, but to work together in partnership with institutions, administration, policymakers, and education system.
Thank you. I've got maybe 2 points to highlight in this. One, to pick up on the education theme. I'm actually going to take home some homework based on what you have said, because we also have a very good announcement that went out yesterday. Lots of great things happening at HSO and Accreditation Canada. That Accreditation Canada will now be the official, we will be accrediting not only all the health services, but all the allied health education programs in Canada. So that means that basically all except for nurses and physicians and a couple of others, so paramedics and lab technicians and all of those education programs, we start in January of taking over a program that used to be run in a different way, and now we are the accreditor of choice, and they will be using, and we will be doing that. So I'm thinking, as you're speaking, boy, this standard, when you develop it, will be wouldn't that be interesting to link this, this standard around communication for minority language situations, not only in healthcare, but let's tackle, given that we're already accrediting all the education institutions, let's tackle that as well. So that is an opportunity. I didn't realize, I hadn't connected those dots yet, so thank you. That's very, I agree completely how important those connections are. The other things are that, that are just part of the standards that I think relate to the questions in a specific way is around interpreters. So there'll also be a fair bit of work in the standards around that, because it relates to access and the safety issue around the requirements for providers in terms of using interpreters, specific actions to ensure interpreter coverage at all points of access, at all times of the day and night, and to address what are the issues of using family members as interpreters, and there's all the issues around privacy and all the family dynamics and all of those things, and also the training and education of interpreters. So the technical committee will be tackling these issues and providing guidance on those. And I think that area is a really important one. And I know, having been CEO and led multiple organizations, of what a challenge it is sometimes to find the right kinds of services, and how do you do this well, not only in French and English, but in other languages as well. So the interpreter issue, I think, would be one I'd like to highlight as a challenge, and we're going to tackle that one as well with you.
Another question, in your opinion, what are the opportunities that must be seized in order to exercise a real change in culture and make the language a security and quality issue recognized and taken seriously? Would you like to start, Ms. Thompson?
So, culture is everything, and I think that's where it's going to take all of you and us and others who are really thinking about how do we create the conditions for the kind of the willing and enthusiastic adoption of these kind of standards, guides, rules, whatever, because even if we have all these things in place, nothing will happen if we're not capturing the hearts and minds of people and really creating the conditions for success with them, and make this part of just how we do things with patients and families. I do think, and very much again from my experience of working in multiple ways, one of the most powerful forces of change for in organizational culture are the voices of the patients and families themselves. And we've taken some very big steps of involving and engaging patients and families in everything that we do to ensure that kind of there's no room to kind of work around that. That's the center of who we are and what we do. And so we're now involving patients and families in the design of standards. Every technical committee will have 25% patients on it for every standard that gets developed from here in. We even now in the assessment of it will be of this standard as well as other care standards. Patients as surveyors, we are now training. And our first cohort, there are a significant number of French-speaking patients and family members who are part of that initial team that they will be part of surveying as well. And I believe that when you include the voice and the perspective of patients and families around almost any issue that is fundamental to quality and safety in healthcare, that the conversation starts to change and it becomes different when they are there. And I would say let us never be trying to do this alone, because this is very important.
Yes, I would definitely agree, and I would also add that the term you mentioned, winning hearts and minds, I think that's absolutely critical. And I would have another, perhaps a comment here, muscle in on change, because I think every change brings itself, it's an opportunity in itself, and we've seen some of those examples today. I just wanted to think, I was thinking too about some of the campaigns that have been successful over the years and what's made them successful. And it led me to think about a hand washing campaign that we had in Wales a few years ago, where that improved staff uptake and infection rates. And it was a very simple campaign. It used a sort of drip feed approach, posters, reminding people all the time. So thinking about that psychology really of how do you actually embed change. A lot of our university, we have a psychology department in Bangor University, and many of our young PhD students are actually looking now at issues around nudge theory to see how they can actually use that and embed that in these sort of situations. And perhaps I'd add one further concept here, was this establishing champions. Recognising champions, yes, who may be designated champions at a sort of higher level, but we can all be champions. We've got student nurses on our programmes who sign up to being a champion for active offer from year one, and they help us. They create their own videos, they create their own discourse, and they find that they go on their clinical placements and they make a difference. So I think it can happen at all levels.
Well, I think that everything is on our side, at least from the Basque and Welsh perspective. We have the legal framework. We have, even as you have pointed out, the opportunity to create new standards, for example. And a firm ground that is the new paradigm. I used to say that we now work in a patient-centered and integrated care model. So, well, I think that all we are here today agree entirely. We want to receive healthcare in our own language and want to offer healthcare in patients' language. But I think that our great challenge is to convince our colleagues, our policymakers, stakeholders, and managers. I mean the monolinguals, those who only speak English, those who only speak Spanish. So how to persuade these people? Okay, so I think that we have to change our mind. I think that to offer healthcare in patients' language offers us an added value as health professionals. Even we can be like bridges over troubled societies, at least in the Basque Country, considering our sad history and sad background. So, and even if you are a stakeholder and manager, this gives you the opportunity to achieve competitiveness, to become a leader, in this field. For example, well, you Canadians have been the leaders in the concept of active offer, de facto, for example. You have done a very magnificent research, and we the Basques have not brain. We have done research, nothing, but anyway, we have the opportunity of a strong arm, because we have in the next few years we will have available thousands of bilingual professionals to implement, to achieve a normalized healthcare. So I think the most important thing is to integrate this concept of adequate, integrate patient-centered care in the whole system at all levels. Users, health professionals, managers or stakeholders and policy makers. Try to convince them, okay? So I think that competitiveness, leadership, added value, things like this. And just to say that we have to change, and we need to change our way of thinking, and to change our practice. Just to finish, I will not say more because I don't speak English very well, but I would like to quote Musa Anter. I am Basque, and I come from a very conflicted background. We tried to rehabilitate, or to make the rehabilitation of our language many years ago in the 30s, but all this generation was martyred. The Basque poets, the Basque literatures were annihilated. Musa Anter was a Kurdish poet that was martyred only for his language. And once he said, if my mother tongue is shaking the foundations of your state, that means probably that you have built your state on my land. So we have to change, and our colleagues must change. I mean our monolingual colleagues, health professionals and managers. If our mother tongue, if our patient's language is shaking the foundations of your practice as a health professionals, that means that you have not strong evidence, you have not a firm ground. Maybe you have changed this evidence. Maybe you have new ways to look at the old evidence. Maybe you must speak a new idiom. This new idiom is the patient-centered care. So look to the language not as a challenge, not as a threat, but as an opportunity. Our patient's language should be, it must be a drive to achieve a work, perform, or to work better. Just I'd like to say.